I got glazed over. No, like this glazed over. Okay. I don't know what it is. We're on the abdomen. This is crazy.
We are on the abdomen.
This is like organ galore.
Yes, we are starting a new area. We're starting the abdomen now. So before we go through the usual routine of talking about the bones and then adding on the muscles and then everything else, let me just make a couple comments about the abdomen. And some of this already came up before when we were talking about the thorax, but I want to just make sure everybody's aware that the abdominal organs sit much higher in the body than most people realize. Because the diaphragm arches so high up inside the rib cage, and the things like the liver sit immediately under that dome of the diaphragm on the right-hand side of the body, and on the left, the first part of the stomach, known as the fundus, as well as things like the spleen, sit way up high under that dome of the diaphragm. These organs actually sit much higher in the body than most people realize. And as a consequence, people often illustrate them incorrectly. They'll illustrate the liver, sitting way down in the abdomen, or the spleen and the stomach sitting way down in the abdomen. If you have the rib cage visible, or even if you can't actually see the rib cage, usually just looking at the contours of the outside of the body, you can kind of tell where the ribs would be on the outside of the body. You should make sure that the spleen and the fundus of the stomach and the entire right lobe of the liver would be tucked up under that rib cage, extending way up high in the chest, way up high inside the rib cage. So having made that point, let's talk about, talk about the bones. We've already talked about the ribs and the costal cartilages and the sternum, which of course would sit way up at the upper end of the abdomen. And we've talked a little bit about the vertebrae. So you've seen lumbar vertebrae, and you know what they look like, what some of their distinct features are. So really the only other bone that we have left to talk about in regards to the bony anatomy of the abdomen is the pelvis. And the pelvis consists of two halves. Each half of the pelvis has different names. There's been several different names that have been used throughout history. The os coxa, os meaning bone, and I forget exactly what coxa means, probably means pelvis or hip or something like that. So each half of the pelvis would be a single os coxa, and then there are two of them, obviously left and right. Other names for the two halves of the pelvis are the innominate bone. So the whole left half of the pelvis, the whole right half of the pelvis would be innominate bones. The pelvis itself refers to the entire structure where these two halves, these two os coxae or innominate bones, are fused to the sacrum posteriorly, and then they fuse to one another anteriorly, where the two pubic bones join together to form the pubic symphysis, which is a cartilaginous joint. Now, each os coxa or each innominate bone is actually derived from three separate bones that fuse together during development. In the fetus, these three bones are still separate from one another, and they don't end up completely fusing together until later in childhood. So at the time of birth, these three bones are still partly separate from one another. So those three bones include the ilium, which is the largest of the three bones that makes up each half of the pelvis. That includes things like the iliac crest, which is the ridge running along the superior border of the ilium. That iliac crest is pretty important for the abdomen because a lot of the abdominal musculature has an attachment on that iliac crest. Excuse me. Another bone that also makes up each half of the pelvis is the pubic bone, or pubis, shown here in red. And that also contributes to kind of the anterior border or part of the inferior part of the abdomen. We'll see in a few minutes that there are structures that attach to the pubic bone that are important in the abdomen. And then the third bone that makes up the pelvis is called the ischium. The ischium is the most inferior of all of the bones and also sits more posteriorly. This is the part of your pelvis that you actually sit on when you sit on a chair. All three of the bones contribute to the formation of what's called the acetabulum, which is the name for the hip socket. If you were to look into that acetabulum from the side, and if it still had this color coding, you'd see that these three bones almost look like three slices of pie. You know, that circular acetabulum is split up into three more or less equal slices of pie, all three bones contributing to the formation of that acetabulum. It's the hip socket. It's for the head of the femur to form the hip joint. Right, so some landmarks that are found on these different bones, things that are in particular important to the abdomen. I already mentioned the iliac crest, which runs the whole length of the ilium from front to back. And as I said, there are several abdominal muscles that have part of their attachment on this. At the very anterior end of the iliac crest is the anterior superior iliac spine, often abbreviated ASIS. The fact that it's called anterior means there must probably also be a posterior one, and there is, but it's not labeled on here. There are posterior iliac spines near the back of the iliac crest. And it's anterior superior iliac spine, which implies that there must also be an anterior inferior iliac spine. And sure enough, there is. Just below the ASIS is the AIIS, separated by a little notch here. That anterior inferior iliac spine is not particularly important to the abdomen, but we'll see later when we get into the thigh that there's one of the muscles of the thigh has its origin on that structure. On the pubis, there's a little bump called the pubic tubercle. It sits just a little bit lateral to the pubic symphysis. And notice this dashed line here connecting the anterior superior iliac spine of the ilium to the pubic tubercle of the pubic bone. That line represents the location of something called the inguinal ligament, which we'll talk about more in a few minutes. This is an important ligament that forms part of something called the inguinal canal, which is an important component of the anterior wall of the abdomen. All right, so as I said, really that's the extent of what we need to talk about in terms of the skeletal anatomy. So let's jump ahead and let's start adding some muscles. Yeah.
Was os coxa singular or plural?
Os coxa would be singular, and then os coxae with an E at the end would be plural.
Okay.
Yeah, okay.
You said that there was a posterior iliac spine. Was it inferior or superior?
There's both. There's
both.
posterior superior,
Oh.
posterior inferior.
Thank you.
You couldn't see them on that particular slide because we're looking at the front. Well, we'll come back and talk about those more later when we get into the pelvis and into the lower limb.
Okay.
Right, so I want to talk about the muscles that make up the abdominal wall. So these are muscles that originate near the back of the abdomen. In fact, many of them originate all the way far in the back from the spinous processes of the lumbar vertebrae. And then they wrap around the sides of the abdomen and then wrap all the way around the front. So these muscles completely enclose the contents of the abdomen. They completely enclose the abdominal cavity. Yeah.
So are you talking about specifically the external ligament? Right?
This is just one example. I'll come back and talk about them individually in a minute, but there are actually three different layers of these abdominal wall muscles that wrap around the abdomen. I'm not going to ask you to know the detailed attachments of any of these. So I'm not going to have you worry about the origin or insertion of these abdominal wall muscles. I'm probably not even going to ask you in an exam for their innervation, although I will describe their innervation for you just so you're aware of it, because I think it's an important thing to know, but not something I'm going to test you on. Remember that up in the thorax, we have what are called intercostal nerves. And those intercostal nerves travel all the way around the intercostal spaces. And I'm trying to remember exactly which numbers, but the upper intercostal nerves are going to make their way all the way around to the sternum. But for some of the lower intercostal nerves, like I think starting from about T7 on down, those intercostal nerves are going to travel around the rib cage in the intercostal spaces, but they're actually then going to reach the anterior margin of the costal cartilages. And they're going to then continue beyond the intercostal spaces into the anterior abdominal wall. So just imagine you've got an intercostal nerve that comes around and basically reaches the end of the rib and reaches the end of the costal cartilage. It just keeps going into the abdominal musculature. So those are often referred to as thoracolumbar nerves, because they start out as an intercostal nerve in the thorax, but when they reach the end of the intercostal space, and when they pass the costal cartilage, they then continue into the abdomen. So I think that's from about T7 all the way down to T12. All of those intercostal nerves are then going to continue into the abdomen. So we would refer to them all collectively as thoracolumbar nerves. So those are the nerves that provide the innervation to most of these muscles that make up the abdominal wall. Also, the very first lumbar nerve, the ventral ramus of L1, is going to do something similar. It's simply going to wrap around the abdomen, lying between these different layers of abdominal musculature and innervate these muscles. So all of these muscles of the abdominal wall are all innervated by those thoracolumbar nerves coming from about T7 down to T12 plus T1, the very first lumbar nerve. All right, so let's look at the individual muscles then that make up these layers of musculature in the abdominal wall. So starting here with the most superficial muscle, which is the first one that you'll see when you remove the skin today in lab, is the external oblique. And again, don't worry about the specific attachments. It's originating from several of the ribs and from several of the costal cartilages, as well as the thoracolumbar fascia posteriorly. Wraps around the sides of the body. And then I think you can tell from this illustration that the muscle ends fairly abruptly, like the red, fleshy, muscular portion of the external oblique just kind of ends along this curving line. And I haven't labeled it on here, but this edge where the fleshy part of the muscle ends is called the semilunar line. That's a book that your dissection manual will probably mention, so just so you're familiar with it. Just that then anterior border of the external oblique muscle. But after that point, the external oblique continues as a thin tendon known as an aponeurosis. So there is a thin aponeurosis that continues from the external oblique. And it's going to contribute to this structure that's labeled on here called the rectus sheath. Now, I'll come back and talk about the rectus sheath in a lot more detail later. But for now, let me just mention that the rectus sheath is basically like a sleeve or an envelope of fascia or tendon, really, surrounding another anterior abdominal muscle called the rectus abdominis, which we'll get to later. And this rectus sheath is actually formed from the tendons or the aponeuroses of all three layers of abdominal musculature. So external oblique and the other two muscles I'm going to mention in a few minutes all end in an aponeurosis, thin sheet of tendon. And the aponeuroses of all three of these layers then join together to form this thing called the rectus sheath. One distinctive feature of the external oblique is the orientation of its muscle fibers. As I said, this will be the first muscle you see when you first remove the skin from the abdominal wall. So you'll be able to recognize the muscle right away just because it's going to be the most superficial, the most obvious muscle. But if, once we start dissecting into it and we start dissecting some of the deeper layers, you'll see that the other deeper layers all have different muscle fiber directions. So the direction of the fibers can help you distinguish one muscle from another. The external oblique fibers are oriented in exactly the same direction as the external intercostal fibers. You remember, I don't have a jacket with me this time, but you remember in that thorax lecture where I had a jacket where I could conveniently put my hands in my pockets. You might remember that the orientation of the external oblique fiber, or excuse me, external intercostal fibers was just like my fingers in my pockets. Same thing with external oblique. You see the anterior or downward angle of these external oblique fibers, just like my fingers in my pockets. In fact, I think you can think of the external oblique as being almost an extension of the external intercostals. The only difference is it doesn't have ribs separating it into a series of separate little bands. All right, so just deep to the external oblique is the next layer of muscle that makes up the abdominal wall, which is the internal oblique. And the internal oblique, again, you don't have to worry about the details of its origin, but basically it's originating from the back, from thoracolumbar fascia, but also from the whole iliac crest. You can see some of it originating from the iliac crest. It's going to wrap around the sides of the abdomen, and it's also going to end fairly abruptly and give rise to a thin tendon or a thin aponeurosis, which also contributes to the rectus sheath. The internal oblique, I like to think of it as being basically a continuation of the internal intercostals. And it also has a similar fiber direction to the internal intercostals. So again, with my hands in my pockets, external oblique was my fingers. The internal oblique is oriented like my thumb, so perpendicular to the fibers of the external oblique. Exactly the same as the internal intercostals. In fact, I would say that the internal oblique muscle is the equivalent of both the internal and innermost intercostal muscles up in the thorax. Deep to the internal oblique is the last of these muscles that make up the sides of the abdomen, muscle called the transversus abdominis. And this is roughly equivalent to the transversus thoracis muscle that we saw up in the thorax, which was very limited to just a small area around the inferior end of the sternum up in the thorax. The distinctive feature of the transversus abdominis muscle is that its muscle fibers are not oriented at an angle. They are literally wrapping straight around the body, each muscle fiber line basically in a horizontal plane. So they're not sloping down like the external oblique or sloping up like the internal oblique. They're just wrapping completely around the body. The transversus abdominis also terminates in a thin tendon or thin aponeurosis, which also contributes to the formation of this thing called the rectus sheath. And you can see on this picture, we'll come back to this slide a little bit later to talk more about this rectus sheath, but you can see another muscle that's oriented vertically here in the intra-abdominal wall, which we'll talk about in just a second. But you see that there's a series of sort of a tendinous sheath that surrounds this other muscle. In fact, I'm going to talk about it right now. So in addition to the three thin muscles that make up the three layers on the sides of the abdomen, external oblique, internal oblique, and transversus abdominis, we also have a pair of muscles in the anterior abdominal wall that run vertically from the ribs and costal cartilages and sternum all the way down to the pubic bone. This is a muscle called the rectus abdominis. And there are two separate ones. There's a left rectus abdominis and a right rectus abdominis. And this is the muscle that is actually contained within this thing called the rectus sheath. So if you imagine my arm as being the rectus abdominis muscle, the sleeve of my shirt is like the rectus sheath. It's basically a sleeve of tendon that forms a complete envelope all the way around the rectus abdominis muscle. I'm not going to ask you about details of origins or anything for rectus abdominis. I do realize that I forgot to say anything about the function of any of these muscles. So let me do that now before I forget. The muscles on the sides of the abdomen, so external oblique, internal oblique, and transversus abdominis, they're involved in things like bending the body to one side or the other. They're also involved in rotational movements of the body. These muscles will literally, cause the abdomen to twist, to turn the body to the left or right. But one very important function of the muscles of the abdominal wall is to compress the contents of the abdomen. So basically to squeeze the abdominal organs. And there are several reasons why your body might want to squeeze the abdominal organs. Anybody have any wild guesses why you might want to squeeze your abdominal organs? Wild guesses?
I said to poop.
To poop, right. That's probably the one that we do on the most regular basis. We use our abdominal muscles to push stuff out of our abdomen, which hopefully there's only one way it's going to go. Although it's also useful for having stuff go the other way if you need to. These muscles help you throw up, they help you vomit. And the compression of the abdominal organs also is helpful in breathing. If you want to exhale forcefully, like if you need to blow up a balloon, you need to push air out with a lot of force, you squeeze your abdominal contents, that pushes the contents of the abdomen up against the diaphragm, and it pushes the diaphragm up into the thorax, which compresses the pleural cavities and forces air out, with a lot of force. So you've got the mechanical movements of the body, it's like just, tilting left or right, twisting, bending left or right. You've got the compression of the abdomen for things like pooping and vomiting and even breathing. Yeah.
They just all do them like together.
Yeah. Especially the compression of the abdomen, they all work together for that. The rectus abdominis, on the other hand, which is this, this basically linear straps of muscle in the anterior abdominal wall, I think you can probably imagine that these are your sit-up muscles. Because they're basically connecting the thorax, they're connecting the ribs and the sternum to the pubic bone down in the pelvis. They're going to help you do crunches. So they would actually be involved in flexion of the whole body, flexion of the abdomen, I guess you'd call it. Something else that's kind of unique, kind of unusual about the rectus abdominis is that you look at it closely, only one of them is exposed here. So you have two rectus abdominis muscles. You have one on the left and you have one on the right. It's only the left one here that's been dissected out and exposed. But it almost looks like it consists of several different muscles because you have these separate little patches of muscle separated by these little tendons. These are called tendinous insertions. It's really all considered one muscle. It just has these little tendinous gaps along the length of it. And that's what gives some people, the six-pack appearance in their abs. If they really work out these rectus abdominis muscles doing lots of crunches, and if they have no body fat, you actually see the bulges of formed by the fleshy parts of the muscle between these little tendinous insertions. Question? Yeah.
Is there a reason that you're divided like that?
I have no idea. Yeah. Yeah, I can't think of any other muscle in the body that is split up like that. And I don't know if it's a embryonic development kind of thing, like it's somehow a remnant of the fact that we were segmented worms at one point in our embryology. I don't know. Yeah.
Where are the concerning objects?
Nothing.
Oh, wait, what?
They're not really inserting into anything. They're not attaching to any bone or anything. Literally, it's just like you've got a fleshy chunk of muscle and then the red fleshy part just stops and all you end up with just is a little tendon. And then the fleshy part of the muscle just resumes again after the little tendon.
Can you flex like different segments of it?
Can you flex different segments of it? I don't know. I've never tried. I don't know if anybody has tried. I mean, generally, you know, when you think of doing crunch, it's like you're pulling your whole thorax towards your pelvis. So it's like you're not really using one part of it independently. I don't know if anybody's ever tried to train themselves to do that or not. Casey first.
So it doesn't insert on anything, so its only function is to allow us to bring our thorax to our.
That's
Punching?
yeah. So the rectus abdominis, I guess technically the origin is really on the pubic bone. And the insertion is the sternum and the costal cartilages. Because if you imagine laying on your back doing a crunch, your pelvis basically stays stationary and it's your torso that is moving towards it. So, you know, thinking about how it's usually the insertion that's moving towards the origin. So the two ends of the muscle are definitely attaching to something, you know, connecting the pubic bone to the thorax, basically. But these little tendinous insertions, these little gaps, are not attaching to anything.
So its function is just crunches.
Yeah, so technically speaking, the function of rectus abdominis would be to flex the torso.
Yeah, that's very odd. And the muscle seems as though it doesn't really have a really distinct purpose, I guess.
Right.
So when I took a anatomy in high school, and we were learning about this, I like thought about it for so long because I asked my teacher the same thing, like, why are they separated like that? And she was like, don't know.
Same to me, it's like, who knows?
So I came up with my own theory. Are you nervous? You know how when you have a straight piece of cardboard and you're trying like a thicker piece of cardboard, you're trying to round it, you have to cut what are those things? Yeah, like cut a slit for it to score it to like round it more.
Yeah.
That's what I thought was like it needed slits so it doesn't just like pull it down, like it rounds it. You know what I mean?
Yeah, I see what you're saying. Maybe.
Anyways, no, I thought like after that lesson she taught us. Yeah, I could.
All right, we'll get to our paragraph. Way in the back there.
They teach, this is what they teach you when the military makes you do push-ups for hours.
Yeah.
It's so you can bend. That's
Yeah,
So it's to increase that range of that motion of that flexion motion. Yeah. It seems like it's good if you read any of that. It's just an excuse to make you do more punches in the military.
Yes. That's so smart. She thought about it for
Yeah. No, it's like I took that class 4 years ago. So.
All right, so that's the rectus abdominis muscle. Let's talk a little bit more about this thing called the rectus sheath that I've mentioned multiple times. So the rectus sheath is, just to repeat what I said earlier, it's derived from these thin layers of tendon, these thin aponeuroses from the 3 layers of abdominal wall muscle. So the tendons of external oblique, internal oblique, and transversus abdominis all joined together to form this thing called the rectus sheath. And I made the analogy before that it's kind of like the sleeve, you know, surrounding my arm. So it's a sleeve of tendon basically that's surrounding the rectus abdominis muscle. Remember that there are two separate rectus abdominis muscles, one on the left, one on the right. So these rectus sheaths coming from the left and right sides then join one another right in the midline of the abdomen, and they form this narrow band of tendon running right down the midline of the abdomen between the two rectus abdominis muscles, known as the linea alba, which literally means the white line. Very important structure for surgery, because anytime you need to open up the abdomen for any kind of surgical procedure, like if you really have to do an open procedure and get deep inside the abdomen, they'll make the incision along this linea alba, because then they don't actually have to cut through any muscle at all. They don't have to cut through the obliques. They don't have to cut through rectus abdominis. They're just cutting through this little band of tendon in the midline, between the two rectus abdominis muscles. Right, so interesting thing about the rectus sheath is that the structure of it is a little different higher up in the abdomen, higher up around the rectus abdominis, and then the structure of it changes a little farther down. So what exactly do I mean by that? How does the structure of it change? This is a cross-sectional view through the anterior abdominal wall. And just to orient you, what we're looking at here, we've got the three layers of muscles that make up the abdominal wall. So external oblique, internal oblique, and transversus abdominis. You see it here on the left side of the slide, and again, mirror image over on the right side. And higher up in the abdomen, the external oblique aponeurosis, if you were to follow it over and see how it is that it contributes to the rectus sheath. By the way, you've got these two sort of long ovals. Those are the rectus abdominis muscles enclosed within the rectus sheath. So the external oblique aponeurosis lies completely anterior to both rectus abdominis muscles. So the external oblique aponeurosis always contributes to basically the anterior part of the rectus sheath. The next layer of muscle, the deeper layer, which is internal oblique, if you follow its aponeurosis medially towards the rectus abdominis muscle, what you find is that the aponeurosis of internal oblique actually splits. And half of its thickness lies anterior to the rectus abdominis muscles, so making up the anterior part of the rectus sheath. But the other half of the thickness of the internal oblique aponeurosis lies posterior to the rectus abdominis muscles, and therefore is making up part of the posterior part of the rectus sheath. And then the transversus abdominis, if you follow its aponeurosis all the way over medially, it lies completely posterior to the rectus abdominis muscle. So it's also contributing to the posterior layer of rectus sheath. All right, so you've got external oblique, anterior, transversus abdominis posterior, and then internal oblique is actually splitting so that part of it lies anterior and part of it lies posterior to the rectus abdominis muscles. So they create this complete sleeve or envelope totally surrounding the rectus abdominis muscles. And then those two rectus sheaths meet right in the midline between the two rectus abdominis muscles to form that linea alba or white line. But as you continue down into the abdomen, roughly halfway between the umbilicus and the pubic symphysis, so a few inches inferior to the umbilicus, there's a very sudden change in the structure of the rectus sheath, where all of a sudden at that point, like I say, a couple inches below the umbilicus, roughly halfway between the umbilicus and the pubic bone, all of a sudden, all of the fibers of these aponeuroses, all of the fibers of external oblique, internal oblique, and transversus abdominis suddenly jump to the front of the rectus abdominis muscles. And the posterior part of the rectus sheath simply ends. And there is no posterior rectus sheath from that point down. So using my shirt sleeve as an analogy for the rectus sheath again, you imagine the shirt coming down and it's completely surrounding the rectus abdominis on both sides. I don't want to take a pair of scissors and slice up my shirt, but if you can imagine that below a certain point, the rectus, my sleeve continued in front of my hand, but then on the back, it just ended and didn't continue. So the posterior part of this sleeve just stops. And you can actually sometimes see the exact point where this transition happens. It's a little tricky to see in the cadavers, but I have seen it a few times in the cadavers. It forms something called the arcuate line. Let me jump ahead here. If you look right here on this Netter picture, you see that it's labeled arcuate line. It looks like there's a layer of tendon or sheath that just ends abruptly right along that arcuate line. So that's the point where the posterior part of the rectus sheath ends, and instead all of the fibers of all three aponeuroses are jumping to the front and contributing entirely to the anterior part of the rectus sheath. So above that arcuate line, the rectus sheath is a complete envelope or complete sleeve, totally surrounding the rectus abdominis in the front and the back. But then below that arcuate line, the posterior part of the sheath simply ends, and the whole rectus sheath ends up on the front of the muscle. I have no idea embryologically how that happens, or if there's any functional significance to that either. Okay, so here you see the rectus sheath. It's kind of sliced and diced in kind of a strange way, the way Netter painted this. But you see the rectus abdominis muscle. You see there's a little bit of rectus sheath that he left intact in this particular picture, in this dissection. Then you see the rectus abdominis muscle actually cut and removed so that you can see that arcuate line and see where the posterior part of the sheath ends. And then once again, you see that linea alba running right down the midline. The umbilicus, by the way, or belly button, sits right in that linea alba in the midline. The other thing to notice on here is that there are two sets of vessels that are traveling with the rectus abdominis muscles running vertically in the anterior abdominal wall. So near the upper part of the abdomen, these vessels are known as the superior epigastric vessels. And when I say vessels, I mean artery and vein running together. So there are superior epigastric vessels up here. These superior epigastric vessels are actually the continuation of the internal thoracic artery and vein that we saw inside the rib cage. So when we removed the front of the ribs, along with the sternum, you remember there was that internal thoracic artery and vein running vertically along the inside of the rib cage, just immediately lateral to the sternum. Well, once the rib cage ends, those internal thoracic vessels continue down into the abdomen to form these superior epigastric vessels. And usually we find those either on the posterior surface of the rectus abdominis muscles, or in some cases actually embedded within the rectus abdominis muscle. And you see in this Netter painting, you might be able to tell if you look closely that Netter is showing the rectus abdominis muscle sort of sliced into in order to be able to see those superior epigastric vessels. There's also a set of inferior epigastric vessels, and these are branches off of some of the iliac arteries down here in the pelvis. So there's an inferior epigastric artery that's bringing blood up from the iliac arteries, and that blood would be flowing superiorly through the inferior epigastric artery, and then there's an inferior epigastric vein right alongside of it. The dividing line between what's considered superior epigastric vessel and inferior epigastric vessel is the umbilicus. So if you see these arteries and veins above the level of the belly button, they'd be called superior epigastric artery and vein. Below the belly button, below the umbilicus, it would be inferior epigastric artery and vein. It's a continuous vessel. And so it's another good example of an anastomosis. So you have blood supply flowing down through the internal thoracic arteries into the superior epigastrics, and you have blood flowing up from the iliac artery up through the inferior epigastrics, and then it meets. Okay, I'm going to spend a fair amount of time today talking about something called the inguinal region, the inguinal canal, because it's an important region of the body medically, because it's a common site for hernias, what are called inguinal hernias. But it's also kind of a difficult area to understand because there's some really strange anatomic relations and some strange things happening here. So here's a close-up of the lower part of the anterior abdominal wall, right where the abdomen meets the thigh. And just to orient you, what you're looking at up there is the external oblique. And of course, you see the red fleshy part of it, which then ends along the semilunar line and then gives rise to its aponeurosis. So all this white tendon here you're seeing is aponeurosis of external oblique, which again is contributing to the rectus sheath over the rectus abdominis muscles. But that external oblique aponeurosis also, down here where the abdomen meets the thigh, that external oblique aponeurosis is also forming some of these other structures down here. There's a little opening in the fibers of the external oblique aponeurosis, represented here by this little green line. This is known as the superficial inguinal ring. It's literally a gap or an opening in excuse me, in the external oblique aponeurosis. And if you happen to have a male cadaver, you'll see this thick muscular tube emerging from that superficial inguinal ring. This is a structure known as the spermatic cord in the male. And we'll talk more about that in detail in a few minutes. But basically, it's the structure that's carrying the vas deferens, which is carrying sperm from the testes into the abdominal cavity. The vas deferens is passing through here, as well as the testicular artery and vein, the artery and vein that are supplying blood to the testes down in the scrotum. So the spermatic cord is basically the connection between the interior of the abdominal cavity and the testes, which are in the scrotum, which is outside of the abdominal cavity. So we've got this superficial inguinal ring. Like I said, it's an opening or gap in the fibers of the external oblique. And this spermatic cord emerges from that opening. There's also something called the deep inguinal ring, which is not part of the external oblique. It's actually a gap in the two deeper muscles. It's a little gap or a little opening in the internal oblique and the transversus abdominis. And the structures inside this spermatic cord, the vas deferens and the testicular artery and vein, are actually passing through that deep inguinal ring to the interior of the abdominal cavity. And these two rings, the deep inguinal ring, which is a hole through the deeper layers of muscles, and the superficial inguinal ring, which is a hole through the external oblique, they're connected by basically a tube called the inguinal canal. And the whole roof of that tube, or you think of it as like a tunnel, the whole roof of that tunnel is formed by the external oblique aponeurosis. So I like to think of this inguinal canal as literally being like a tunnel through a mountain. You've got an opening at one end, which is the entrance to the tunnel. That could be the deep inguinal ring, which is essentially an opening into the interior of the abdominal cavity. And then you've got an opening at the other end of the tunnel, which would be the superficial inguinal ring, which would be an opening through the external oblique aponeurosis. There's a train in this tunnel. The train is coming in one end of the tunnel, the train is lying in the tunnel and coming out the other end of the tunnel. In the male, that train would be the spermatic cord, would be this muscular tube that contains the vas deferens, the testicular artery and vein, allowing those structures to basically pass from the inside of the abdominal cavity through the abdominal wall to then reach the testes, which are basically outside of the abdominal cavity, hanging down in the scrotum. The roof of that tunnel, the mountain, if you want to think of it as that, you know, that makes up the roof of the tunnel, is the external oblique. It's the fibers of the external aponeurosis, which is forming the covering over this tunnel. And oh yeah, I guess it is labeled here on the right side of the slide. Way back at the beginning of the lecture, when I was talking about the pelvis, I pointed out there were two bony landmarks, the anterior superior iliac spine on the ilium and the pubic tubercle on the pubic bone. Those are connected by a ligament known as the inguinal ligament. And the inguinal ligament is labeled here on the right side of the slide. That ligament that stretches between those two bony landmarks, you can think of that as the railroad tracks that the train is traveling on. The inguinal ligament forms the floor of the inguinal canal. Okay, so we got the train coming into the tunnel from the inside of the abdominal cavity through the deep inguinal ring, which is a hole through the internal oblique and transversus abdominis. The train travels through the tunnel, you know, it's sitting here in the tunnel, covered by the external oblique aponeurosis, and then the train finally exits the tunnel through the superficial inguinal ring, which is an opening in the external oblique fibers, and then the train comes out the other end. So males, of course, have a spermatic cord because males have a vas deferens, and they have testicular arteries and veins, which have to leave the abdomen to go to the testes, which are basically outside the body. In the female, there is no spermatic cord, although interestingly, they still have an inguinal canal. Female cadavers will still have a superficial ring and a deep ring, but instead of having this big, thick, muscular tube, which is about as big around as your finger, instead of having that spermatic cord, females will have a very tiny, delicate little ligament called the round ligament, which inside the pelvis is actually a suspensory ligament of the uterus. It actually helps to support the body of the uterus inside the pelvic cavity. But by the time it exits the superficial inguinal ring, it's very, very tiny, and unfortunately, really, really hard to find. I think in all my years of teaching anatomy, I've seen like maybe 4 of them. They're just really, really hard to identify. So if you have a female cadaver, you can certainly look for the superficial inguinal ring and take some time and look for the round ligament, but don't be surprised if you have trouble finding it. You're going to want to look at one of the male cadavers because that spermatic cord is going to be much, much more prominent, much more noticeable. So let's talk in some more detail about how this forms, because it's kind of strange and kind of hard to wrap your head around this idea that you have this tube that's basically connecting your inside of your abdominal cavity to the outside world. And the formation of this tube, at least in the male, is related to the descent of the testes and the migration of the testes from inside the abdominal cavity to their final position in the scrotum outside the body. So the testes actually begin their embryonic development high up in the back of the abdomen. Their development is very closely related to the development of the kidneys, way up in the back of the abdominal cavity. But during development, the testes begin to actually migrate downward from their position. So they start way up here high in the abdomen, but then they begin to migrate downward and also anteriorly towards the anterior abdominal wall. And as they migrate, they're actually carrying their blood supply and their nerve supply with them. So they're sort of dragging the testicular artery and the testicular vein with them, testicular nerve, which innervates the testis. And what's not shown here is that they're also carrying the vas deferens or ductus deferens with them. And there's this little ligament that seems to be involved in this process of the descent of the testes. Originally, this ligament was longer and it connected to the testis way up high in the abdomen. And gradually, as the testis is dragged down towards the anterior abdominal wall, this little ligament gets shorter and shorter and shorter. It's known as the gubernaculum. I've always kind of enjoyed that name. The first time I learned about this gubernaculum, this little sort of tendinous structure that is anchoring the testis during its descent, I used to imagine that this gubernaculum was like a rope, and like somebody's down there just pulling this testis down towards the anterior abdominal wall. And I don't think it really does that. I don't think it's actually pulling anything. I think the testis is essentially migrating on its own somehow. And the gubernaculum simply gets shorter and shorter and shorter as the testis moves down towards the abdominal wall. So it's not like the gubernaculum is literally pulling the testis down. Eventually, the testis reaches the anterior abdominal wall, and it encounters those 3 layers of abdominal muscles. Transversus abdominis initially, which is the innermost layer, internal oblique, and then finally external oblique. And the testis actually begins to push through those layers of muscle to create the gaps in those muscles. So it's going to push through the transversus abdominis and internal oblique to create the deep inguinal ring, which is, a gap in those 2 muscles. And then as it continues to push its way down through the abdominal wall, eventually it's going to push all the way through the external oblique as well to create the superficial inguinal ring. And the testis will then basically push its way out and then continue down to its final position down inside the scrotum. You're probably all aware that some male infants are born with an undescended testicle. In fact, sometimes both undescended. Oftentimes the testis will be kind of stuck partway on its journey, and they haven't actually dropped all the way down into the scrotum yet. And I don't remember exactly like what age that's supposed to be done. I mean, they're supposed to be fully descended at the time of birth, but I don't think it's a big deal if one of them hasn't fully descended yet at the time of birth. At a certain point, it becomes a little bit more of an issue, and then they actually have to do surgery to kind of help it along its way. So the testis ends up sitting down here in the scrotum, dragging its blood supply and nerve supply with it, as well as the vas deferens, which isn't shown on here. And that gubernaculum still persists. It's actually now anchoring the inferior end of the testis to the inside of the scrotum. So this slide is, sorry. Oh, yeah, go ahead.
Inferior end of testis to what?
To the scrotum. The inside of the scrotum.
I'm just wondering, in the previous image, it kind of looks like it was not just pushing through the muscles, but almost like the muscles were going, or the other one, it
Yep.
looks like it was like pulling the abdominal wall muscles around it.
Yeah, I drew it like that on purpose.
Is there like the same abdominal wall muscles are on the back from the front and tail?
So the testis does more than simply push through the muscles to make these gaps. As it's pushing through and as it's creating these openings through the 3 layers of abdominal muscle, it's also carrying some elements, some components of those 3 layers of muscle, actually 2 out of the 3 layers of muscle with it, which then actually become the layers of the spermatic cord itself, that actually become the layers of that muscular tube. So I'll actually show that in much more detail in just a minute. So before I do that, though, just a comparison showing that there are homologies or similarities between some of the reproductive structures in the male and in the female, and structures are color-coded. So the testis in gray is equivalent embryologically to the ovaries in the female. The gubernaculum, which anchors the testis to the inside of the scrotum, is the same thing as the round ligament in the female. That's the structure that in the female is actually passing through the inguinal canal. And its function in the adult is that it actually helps to support the uterus within the pelvic cavity. But it's interesting that this gubernaculum in the female is basically following the same migratory path as the testis in the male, basically pushing its way through the layers of musculature. Instead of being anchored inside the scrotum, the round ligament simply anchors itself inside the skin of the labia majora in the female. Yeah.
Is it possible for them not to migrate down and like a child being born with their reproductive organs and?
Yeah. Well, certainly in males, it's, I don't know how common exactly, but it's common enough that it's not that big a deal. That you have what's called crypt orchidism. Crypt meaning like hidden, orchid referring to the gonads. So that's just a fancy name for undescended testicles. So in some males, when they're born, they haven't descended at all.
Like adults.
At all.
Still in the, like.
I mean, they probably wouldn't be way back in the upper abdomen. They'd probably be down in the pelvis, but they hadn't pushed their way
Yeah.
through.
Like you were saying.
Oh, yeah.
But what about for women in their uterus? Like abdomen?
I've never heard of that, but that doesn't mean it doesn't happen. I'd have to look into that more to see if it ever happens that the ovaries are sitting higher up in the abdomen.
So the round ligament is like almost not equivalent, but it is equivalent to the
Gubernaculum. Yeah, they're homologous structures. It's like in the early embryo, before there's any difference between male and female, they are the same thing. And they just end up developing differently depending on which way, the fetus goes during development. All right, so I was mentioning before about the fact that not only does the testis push its way through these different layers of musculature to create these openings, the deep inguinal ring and the superficial inguinal ring, but as it does that, it also drags a little bit of each layer with it, which then end up becoming the layers of the spermatic cord itself. So it's a little bit of a confusing picture at first, but once you look at it closely and understand what it's showing, it makes a little bit more sense. So we've got the testicular nerve, artery, and vein. This time I actually put the vas deferens in there. So vas deferens joining it here in green. And these structures are all inside the abdominal cavity, and they need to find a way to get out of the abdominal cavity to get down to the testis down in the scrotum. So they are then passing through, come on, cursor. Come on, there we go. They're passing through this opening in the, there's another structure on here that we haven't talked about before. I forgot that I didn't mention this before. There's a layer of fascia inside the abdominal cavity called the transversalis fascia. It's really essentially fascia that's on the inner surface of the transversus abdominis muscle. But as the testis pushes its way through the abdominal wall, it's first going to push through that transversalis fascia. And as it does that, it actually ends up dragging the transversalis fascia with it to form the innermost membrane of the spermatic cord, something known as the internal spermatic fascia. Okay, so transversalis fascia in the abdomen is dragged into the interior of the spermatic cord to form the internal spermatic fascia. The transversus abdominis muscle itself actually does not make any contribution to the spermatic cord. So the testis simply pushes a hole in the transversus abdominis, but none of the transversus abdominis actually gets dragged into the spermatic cord. It's just, there's just a gap in it. The internal oblique, on the other hand, that also forms part of the deep inguinal ring, but part of the internal oblique gets dragged down into the spermatic cord and forms the middle membrane that makes up the wall of the spermatic cord, called the cremasteric fascia. And it actually forms a muscle in the wall of the spermatic cord known as the cremaster muscle. So when you first see the spermatic cord, it looks like a muscular tube. And the muscle that you're seeing that makes up the wall of the spermatic cord is this cremaster muscle that's derived from the internal oblique. And then finally, when the testis pushes its way all the way through the abdominal wall, it pushes through the external oblique to create the superficial inguinal ring. But the external oblique is also contributing a little bit to the spermatic cord, forming the outermost membrane, the outermost layer, which is the external spermatic fascia. So the spermatic cord itself is made up of an external spermatic fascia coming from external oblique, a cremaster muscle coming from internal oblique, and an internal spermatic fascia derived from the transversalis fascia inside the abdominal cavity. And all of this surrounding testicular nerve, artery, and vein, and vas deferens. So this is an absolutely brilliant picture by Dr. Netter that shows this set of relationships probably better than just about any other illustration I've ever seen. And again, it may be a little confusing when you first look at it, but once you kind of think about it and read through it, it makes a little more sense. So we've got anteriorly here, we've got the rectus abdominis muscles. This would be the most inferior end of rectus abdominis, where it's attached to the pubic bone, surrounded by rectus sheath. You can actually see how that rectus sheath is formed from the aponeuroses of the different layers of muscle in the abdominal wall. Over here, you can see external oblique, internal oblique, and transversus abdominis. And then there's another layer in here, which apparently I didn't label. That's that transversalis fascia, which is, inside the transversus abdominis muscle. So then we've got testicular artery and vein up there, vas deferens, and all of those things are then pushing through the transversalis fascia. But if you look really closely, you may be able to tell that in addition to pushing through the transversalis fascia, it's also sort of dragging a sleeve of transversalis fascia with it, which will become the internal spermatic fascia. Then you've got transversus abdominis, and there's just a hole in the transversus abdominis, which is the deep inguinal ring, and that muscle doesn't contribute at all to the spermatic cord. Then you've got internal oblique, and there's a gap in the internal oblique, which is also part of the deep inguinal ring. But right there, there's just this tiny little sliver of muscle that's being dragged off of the internal oblique. And that's what's going to, unfortunately, the label here says inguinal canal, but that little strip of muscle right there is important because that's what's going to become the cremaster muscle in the spermatic cord. And then finally, we've got external oblique on the outside here. You can see how the external oblique fibers are what are actually forming the roof of the inguinal canal. And finally, there's a gap in the external oblique down here, which is the superficial inguinal ring, allowing the spermatic cord to then finally leave. Although external oblique is also contributing that outermost layer of fascia, the external spermatic fascia to the outside of the spermatic cord. So then you got this big muscular tube now that's going to continue down into the scrotum. This cremaster muscle is really kind of an unusual thing. I actually do know the function of this one. I mean, you guys keep asking good questions about what's the function of X, Y, or Z, and I don't have any idea. The cremaster muscle does something kind of weird. It pulls the testes up towards the body, presumably in response to danger, like, ooh, something's too close to my testes, better pull them up, get them out of the way. Yeah, I know, that's kind of amusing. I got a video here. Let's see if this will actually play or not. So this is obviously a little boy, and someone is going to demonstrate this cremasteric reflex or cremasteric response. And apparently scratching the inner thigh can evoke this response. Seems to be more pronounced in younger boys. Let's see if this will actually, come on, damn it. And you're not working. Oh, I know what it is. Sorry, let me get out of here for a second. Let me try to place that again. Insert video. What? My flash drive? Too smart. So I've had this movie in this lecture for years. And then suddenly, when I was previewing the lecture on my laptop the other day, it said, hey, we don't know where that movie went. And it's like, really? All these years you've known where it was, and now suddenly you get confused and don't know where it is? I don't know, you probably won't be able to hear the audio here in the room. And another brilliant thing, I don't know, good old Apple and their technology. It's like, I don't have a volume button on here anymore to increase the volume. But so hopefully the video will work now. Yeah, so that's the cremaster muscle actually pulling up on this kid's right testis.
You could also do it for temperature.
There's a different muscle
Different.
actually in the skin of the scrotum called the Dartos muscle. And I'm sure you're referring to the fact that the scrotum can become very tight and kind of wrinkled up, and that responds to temperature, and that also basically holds the testes closer to the body to keep it warmer.
That muscle's in the skin. Where is this muscle located?
This muscle is one of the 3 layers of
One of the 3 layers.
tissue that makes up the spermatic cord itself. Okay, so like I say, when you do your dissections, regardless of whether you have a male or female cadaver, you actually want to skin down into the upper part of the thigh a little bit and into the upper part of the groin a little bit. So I think in the book, they tell you to extend your skin incision at least 3 centimeters, so like 1.5 inches, inferior to the anterior superior iliac spine, and also inferior to the pubic bone. So you want to palpate the pubic bone, the pubic tubercle on your cadaver, and make sure that you're actually inferior to both of those bony landmarks. Because in order to really be able to see any of this structure in the inguinal region, you actually have to extend, you actually have to incise down into the upper part of the thigh a little bit. So when you initially finish skinning and removing all of the fat in the superficial fascia, hopefully you'll actually be able to see this superficial inguinal ring. And of course, it'll be a little easier in the male cadaver because you'll have that great big thick spermatic cord sitting there as a landmark. It's a little trickier in the female just because the ring itself is smaller and there's no obvious structure coming through it. You're going to want to try to leave all of that stuff intact on one side of your cadaver. So don't dissect deeper on one side or the other. But on the other side, you're going to want to dissect deeper to see the actual spermatic cord sitting in the inguinal canal. So this is what it should look like by simply removing the external oblique, because the external oblique is forming the superficial inguinal ring. It's also forming the whole roof over the canal. So by removing or reflecting external oblique out of the way, you've basically taken the whole roof off of the tunnel, so to speak. And so now you can see the spermatic cord actually sitting in the inguinal canal, completely exposed. And now you can see the deep inguinal ring passing through the internal oblique and also through the transversus abdominis. This area is clinically important. I mentioned briefly before that this is an area where you get hernias. There's lots of different kinds of hernias. There's lumbar hernias, there's umbilical hernias near the umbilicus. But usually when most people say hernia, they're talking about an inguinal hernia. And in an inguinal hernia, what happens is that you have something inside the abdomen, some of the contents of the abdomen actually work their way into the interior of the spermatic cord and travel down actually inside the spermatic cord. And it could just be a little bit of fat, which is usually not that big a deal, but in some cases, it's an entire loop of intestine that can manage to work its way into the interior of the spermatic cord and actually pass internally inside the layers of the spermatic cord and all the way down through the deep inguinal ring and the superficial inguinal ring to create this big hernia pouch that may in many cases actually protrude out of the superficial inguinal ring. And this can be bad for a lot of reasons. It can be very painful because it can actually compress the testis inside the scrotum. It can cut off the blood supply to the scrotum, to the testis. But it's also very bad because you try to shove a whole loop of small intestine down into this little narrow tight passageway. You're basically cutting off the ability for food to flow through the intestine, and you can even cut off the blood supply to that loop of intestine, and that loop of intestine can become necrotic, which would then require removal of part of the intestine.
So you get surgery to fix that, and then just pull the intestine back up again? Like,
Yeah, there's two different ways to do the surgery. You can do it from the outside, you can do it from the inside. They do it from the outside, they basically just poke it back in.
Yeah, because I know people, that's what people do, like to maintain it, like before they get surgery, they just poke it back.
Yep. Yeah, so the older approach to the surgery was to always do it from an external approach. Basically just poke the hernia pouch back up into the inside of the abdomen. And then they would take a piece of plastic mesh, looks like a window screen, and just either suture or staple it over the inguinal canal to kind of strengthen that part of the abdominal wall. The reason that these inguinal hernias are so common is because the deep ring and the superficial ring are areas of weakness in the abdominal wall because it's literally a gap in the muscles. So loop of intestine can work its way in there and then basically travel unimpeded down through the spermatic cord. So they'll place this mesh over that area to try to reinforce it. The internal way is they just go in laparoscopically, they put a camera and some instruments inside. In that case, they'll have to pull it up from the inside, pull the pouch up, and then they just put a piece of mesh on the inside of inside the deep angle ring.
Why are the deep superficial rings weaknesses?
Because the deep ring is a gap, an opening, a hole in the transversus abdominis and internal oblique. So that represents the area of weakness in the abdominal wall. And the superficial ring is a gap in the external. So basically, you've got gaps or holes in some of those 3 layers of muscle that make up the abdominal wall.
Why would the intestines move at all? I mean, I know they're moving, but why would they like, is there something that's like pulling them down? What would make them, how would they like think, oh, little opening, go through? You
Guess
know I'm
what?
saying?
Yeah.
Like, it's not big enough for them, so why?
Yeah. Every time you compress your abdominal wall, which you do when you poop, when you cough, when you have to exhale forcefully, when you throw up, I don't think that's usually a big contributor. But also, I didn't mention this before, but oftentimes when you're lifting something heavy, you'll tighten up your abdominal walls to kind of strengthen your core. And so that's compressing the internal contents. So we often associate hernias with people who lift heavy objects and don't do it, ergonomically. I think people get hernias even just from being constipated, just that pushing.
It happens like over time.
Yeah, usually they develop gradually over time.
Could you
Oh.
like reverse it? Like, how could you be like, oh, I think it's happening, and like do something to like stop it?
Kind of suck your abdominal contents in. I don't think so. I don't think there's any way to do that.
Okay.
Casey, did you have another question?
I don't. That's strange.
Okay. All right, well, it's a couple more slides in this lecture, but we're already over time, so I'll come back to these and finish these up next time.